So now this should be the last video for musculoskeletal pathology, and then we'll be able to go into dermatology and finally wrap up pharm here. I'm really excited to get to pharmacology here specifically because this is the pharm chapter that's actually really relevant in terms of NSAIDs, which is a pretty big topic. The last few topics right now, we're going to be looking at polymyositis versus dermatomyositis and myasthenia gravis versus Lambert Eaton, both of which are pretty big deals, right? All four of these diseases, or both of these sets of diseases, are pretty big deals. They can have various presentations, and oftentimes it's really easy to make any of these questions just look difficult. So be ready for that. Let's see. First things first. So polymyositis, right? Both of these are going to have antibodies associated, right? So the non-specific thing is positive anti-nuclear antibodies. You're going to have elevated CK because there is myelitis here. The specific stuff here now that is more specific to both, basically, not one or the other, are your anti-Jo1 and anti-SRP as well as anti-mitochondrial antibodies, right? So you can see they have multiple names as well. Each one of them has two names, which is pretty annoying. Usually they use the names that are in the parentheses from what I've seen. Very rarely have I ever seen this as an answer choice or anti-SRP. Right, well, SRP just works out because SRP actually stands for signal recognition particle, but I have seen anti-mitochondrial antibodies that don't really tend to write the helicase, but this they write. This thing is always this. I've never seen anti-Jo1 as an answer choice. So any of these three antibodies, if you see it in a question, you should immediately think of one of these two diseases. Anti-nuclear antibodies can be found in other things as well, so it's not exactly a giveaway for polymyositis or dermatomyositis. So what are these two diseases? Well, polymyositis is a progressive symmetric proximal muscle weakness characterized by endomysial inflammation with CD8 positive T cells. Most often involves the shoulders, right? But dermatomyositis, although clinically similar to polymyositis, also involves Gottram papules, which look like this, photodistributed facial erythema, which can easily be confused with the butterfly rash of lupus. Right here, they describe it as a heliotrope edema of the eyelids. Shawl and face rash, right, which is seen here. So darkening and thickening of fingertips and sides resulting in irregularity. Dirty appearing marks. There's an increased risk of occult malignancy, which is really important. They don't tell you more about that, but this URL question will tell you more about that. Perimysial inflammation and atrophy with CD4 positive T cells. All right, so we're seeing differences between these two diseases already, but on top of that, the way that they generally present is really overlapping with a lot of other stuff we've seen so far, right? The rashes we're seeing here kind of overlap with stuff we saw in lupus. The muscle weakness that we're seeing, remember in the video right before this one, we discussed fibromyalgia and polymyalgia rheumatica, which are both myalgias, right? So muscle pain. And those myalgias, there's a difference between these two guys as well, right? Polymyalgia rheumatica was the one that was more so related with temporal arteritis. There was normal CK here, but it is inflammatory, right? Polymyalgia rheumatica is inflammatory, so you have ESR and CRP elevations there. But fibromyalgia was not inflammatory. It had tender points, right? This thing here, this was not inflammatory. There was no inflammation anywhere. These patients usually just need to change their lifestyle, right? Regular exercise, possibly take neuropathic pain agents, but other than that, there's really no, a solid explanation for why fibromyalgia patients go through what they go through, right? So lack of ESR, right? No CK elevation there either, because there's no myelitis per se. Let me see. Yeah. And then we looked at some practice questions for both of these diseases as well. It was really evident to catch one over the other. When we were looking at lupus, remember, we just looked at dermatomyositis and polymyositis, and we just talked about the facial rash and dirty appearing hands. Well, I could have just put these pictures and said the same thing too, right? A facial rash. If I pointed at this and told you they're Gottram papules, you really can't argue too much at that point. Gottram papules don't exactly have a very specific type of design or something. So it's really difficult to, just based off of pictures, differentiate between lupus and other things. Lupus, being the great imitator, will often mimic many other diseases, right? So really make sure you know the key differences, as well as make sure you know the specific antibodies associated with each of the diseases. So other than that, between these two diseases themselves, right, polymyositis is endomysial inflammation, whereas dermatomyositis is, where did they put it? Perimysial inflammation. Now, I used to have a picture here to show you what the difference between those two things are, in case you haven't seen it before. So let me find that. Endomysial versus perimysial. I mean, the words kind of give away what they mean anyway, but let's just get this picture. Let me see. That's a pretty ugly picture. Hey, alright, whatever, we'll do it with the ugly picture then. Can't really find a very clear, good picture to explain what the difference between the guys are, but, let's see. So endomysium, right, it wraps one specific fiber itself, right? You can see endo being very, very deep inside, right? It wraps one fiber itself. The whole thing is called a fascicle, and wrapping a fascicle is a perimysium, right? And then the epimysium is the one that's far outside, wrapping all the fascicles together, right? So a fascicle itself, though, is surrounded by a perimysium, and one muscle fiber is surrounded by endomysium. So here, polymyositis, right, is involving the endomysial, right? So endomysial being that polymyositis has inflammation where it's around one muscle fiber, right? So polymyositis I always thought of as surrounding multiple different muscle fibers at the same time, whereas dermatomyositis, this is perimysial, and peri means, next to, so it's basically going to surround the whole fascicle. Alright, so make sure you know that difference, because they don't necessarily need to use the word. They don't need to be like, oh, there's perimysial inflammation. They could just say there's inflammation around one whole fascicle, and then you have to understand that means perimysial. So definitely make sure you catch that, right? Make sure you grab that. The endomysium surrounds single myocyte sarcolemma, where the perimysium surrounds fascicles of muscle fibers. And if they describe that rather than just use the word perimysial or endomysial, you want to make sure you can actually catch that difference. That's pretty much a giveaway. That is a major difference between the two. The other major difference between these two diseases is the immunological part of it, which is the CD8 positive T cells for polymyositis and CD4 for dermatomyositis. That wasn't too hard to remember either, because again, poly means multiple things, so 8 is the bigger number, CD4 is the smaller number, that's just the derm one. I don't know, there really isn't any crazy easy way to memorize any of that, but endo and 8, right, dermato is perimysial and CD4. Look at this question now. So this is a URL question. A 42-year-old woman comes due to muscle weakness, right, comes to the clinic due to muscle weakness. Her symptoms have gotten worse since they began 3 months ago. The patient has trouble with climbing stairs and getting up from a chair. She also reports a 10-pound weight loss, subjective fevers, and occasional abdominal discomfort over the same interval. So right there you can stop and understand that we have two different big issues taking place at the same time, right? One is the fact that she has muscle weakness and it's getting worse. The second thing is this random weight loss without really trying to lose weight. 10 pounds of weight loss without trying to lose weight in America is a blessing or cancer, right? So this is most likely cancer, because those blessings don't really come that easy. And at that point, you want to start associating two things together, right? She has muscle pain and a cancer. That sounds a lot like dermatomyositis. Past medical history has gastroesophageal reflux disease and hypothyroidism, for which she takes medication. So that's not a problem anymore. One thing to keep in mind is oftentimes they'll give you questions like this, right? So give you sentences like this, where they'll tell you something in the past medical history and try to throw you off. But if they also tell you that the patient takes medications for them, and you know the medications for them, right? GERD, most likely taking omeprazole or something. Hypothyroidism, so she's taking levothyroxine. Those two medications, just you have to know what they're really related to in terms of side effects, adverse reactions, all that other stuff. Those two medications don't really have anything significant so far for this patient, so we can wipe that sentence out. That past medical history is very unrelated to anything that's happening to her. Physical exam shows weakness of the shoulder and hip girdles, and an image of her hands shows Gottron papules, like this. Further evaluation would reveal what? And the answer was ovarian adenocarcinoma. there really wasn't any way for you to know that, right? Because they don't tell you that here, right? They only tell you that dermatomyositis has an increased risk of occult malignancy, but they don't tell you where. All right. The other answer choices, however, were PCT, porphyria cutanea tarda, primary biliary cirrhosis, Tropharema Whipple, or type 2 diabetes, none of which are cancers, right? So what was supposed to happen here is you're supposed to go back to the question and understand, we've already evaluated the fact that she has muscle pain, right? And they tell you physical exam, which is an evaluation, tells you where her pain is. The other evaluation would tell you about the cancer, and the only answer choice that was a cancer was ovarian adenocarcinoma. So although there was no way for you to actually know ovarian adenocarcinoma is related to dermatomyositis, if this was you on your actual step 1 and you saw this scenario, you would still pick that because you're looking for a cancer in further evaluation. Right? And then they tell you in UWorld that dermatomyositis is commonly associated with occult malignancy like ovarian, lung, colorectal, and non-Hodgkin lymphoma. So that's the kind of stuff you want to be ready for on step 1. When you get presented something that you're not very aware of, you don't feel like you know off the top of your mind immediately as soon as you read the question. So you really want to be critical about what's happening, right? Become into the mind of the test writer. There's a reason test writers tell you something in a question, and this question is a very good example of that, right? They tell you the muscle pain, they evaluate the muscle pain, physical exam. They tell you she has random weight loss and subjective fevers and whatnot, which are all signs of cancer. And then they ask you, what would you find in further evaluation? You would find a cancer. Okay, you didn't even need to know that this was actually a case scenario of dermatomyositis. All right, but if you could figure that out, that'd be great. And then you would remember that there's a risk of occult malignancy. So that's basically it. I think I've seen another question where a patient shows up, with dermatomyositis. It's almost always going to be a female patient for most of these autoimmune diseases. And they tell you a lot about her hands looking really dirty, and she looks very unkempt, but she's not dirty or unkempt. It's actually just rashes and Gottram papules, right? So you really got to make sure you can kind of evaluate that based off of what's being told. And they tell you later on about like further evaluation, biopsy, blah, blah, and they found inflammation around the fascicles, and inflammation around the fascicle is perimysial inflammation. And the question actually asked you, what would you find? And the answer choices were like CD4, CD8, blah, 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 other things like that. You had to remember that it's CD4. So, there's a lot to remember. I mean, on top of all that, you can also get questioned on the stuff up here. So you would find histidyl tRNA synthetase antibodies, signal recognition particle antibodies, and helicase antibodies. All right. So that's it for that. The other comparison are these guys, and then we'll look at all the questions down here. So neuromuscular junction diseases, right? Myasthenia gravis versus Lambert Eaton Myasthenic Syndrome. These two diseases, although they might have very similar presentations, they're very different from each other in terms of pathophysiology and all that. Frequency, pathophysiology, clinical presentation, associations with other things, and whether or not an acetylcholinesterase inhibitor would have an effect, right? So none of this is guesswork. You just have to memorize some things and really know the pathophysiology of the disease. Let's look at myasthenia gravis first. So myasthenia gravis is the most common neuromuscular junction disorder, which means it's most likely going to be that as the answer for your question test. There in myasthenia gravis, you have antibodies to postsynaptic acetylcholine receptors. You're killing the receptors, right? If you kill the receptor, it doesn't matter how much acetylcholine you make, you don't have a receptor, okay? So that's a problem already. So how do you present? Clinically, you're going to see ptosis, diplopia, weakness, right? Respiratory muscle involvement can lead to dyspnea. Bulbar muscle involvement can lead to dysphagia, difficulty chewing, right? And all of this worsens with muscle use, okay? Because you already don't have many receptors, and the more you use muscle, you're also going to end up running out of acetylcholine, right? So think about that. You're killing off receptors. You only have, maybe, let's just say for ease of discussion, maybe this patient only has 10 receptors to begin with in their whole body, right? And let's imagine that's normal. 10 is the normal number of acetylcholine receptors you're supposed to have in the whole body. And then because this patient has myasthenia gravis, now they're only left with 3. So they lost 70% of their acetylcholine receptors. Now, that acetylcholine they have, many places that don't have the receptor at all, there's going to be no effect there. And the few places that there are receptors, there's going to be effect. But if you start running out of acetylcholine, that's going to be problematic now, right? So worsens with use. And there's a way to memorize it. I'll talk about that too. Associations with is what you usually get tested with. Okay, so they're going to present someone who has ptosis, difficulty breathing, difficulty chewing. They'll tell you that the symptoms are getting worse with use. What else would you find on further involvement? Further investigation, and you would find thymoma. Or you would find thymic hyperplasia or thymoma in a patient with myasthenia gravis. And that association is what they most often test. All right, because diagnosing myasthenia gravis isn't the harder part. Making sure you check for thymoma and prevented that from leading to more complications in a patient is the harder part that they want to make sure, step one writers want to make sure you remember. Now, this last part is just a piss off because they can throw this into a question to kind of confuse you or misguide you. So giving an acetylcholine esterase inhibitor reverses some symptoms, right? Pyridostigmine, and when we were all the way in the beginning, when we were in pharmacology, we saw, in the pharmacology section, we saw they wrote pyridostigmine gets rid of myasthenia gravis, right? Rid, and then O and the GM here, if you swap it around, it's MG, right? So pyridostigmine gets rid of myasthenia gravis, and you have to remember that. Now, compare this, where you're killing off the acetylcholine receptors, compare this to Lambert Eaton. Alright, so compare myasthenia gravis now to Lambert Eaton. In Lambert Eaton, which is very uncommon, now you have antibodies to your presynaptic calcium channels, which means without the calcium, without the calcium flux, you're not going to release acetylcholine anymore. This isn't so bad, right? That's not so bad at all. Your only issue is you're not releasing acetylcholine, so the more you use the muscle, right, improves with use. The more you use the muscle, the more you'll be able to release the acetylcholine. These patients simply present with proximal muscle weakness and a bunch of autonomic symptoms because acetylcholine, right, is part of the autonomic nervous system. And we learned that when we were in pharmacology. Those pharmacology videos tell you everything. Acetylcholine, let me just go back and show you what I'm trying to talk about. When we go to autonomic drugs, right, this is your autonomic nervous system up here. And you can see everything is acetylcholine, right? Initially, everything is acetylcholine. Then in your parasympathetic nervous system, everything is actually acetylcholine. The second thing, postsynaptic, right? Acetylcholine is your rest and digest hormone. The only thing in your sympathetic nervous system that works with acetylcholine are your sweat glands. So you can always remember muscarinic sweat makes you smell musky. It's muscarinic and it uses acetylcholine, right? The M receptor always uses acetylcholine. So you got to remember that. Everything else in sympathetic stuff was not acetylcholine for the postsynaptic stuff. Now, without acetylcholine, you're unable to do anything though. Look, all of these are acetylcholine, so that's a really big problem. You're going to see all these symptoms because they're not going to have a lot of acetylcholine release. And down here, we also saw, right, sympathetic stuff was epinephrine and norepinephrine mostly for all these alpha and beta receptors. The muscarinic receptors, which are parasympathetic, are with acetylcholine. Right, so very important to know the pharmacology, and you can always go back and review that. This might even be a good time to review that if you actually forgot any of that. So Lambert Eaton, if you had to pick between getting one or the other, which disease are you going to take? You would take Lambert Eaton. You don't want to have myasthenia gravis. Now, there is a bad part to Lambert Eaton. The association that Lambert Eaton has is much worse than the association myasthenia gravis had. Having a thymoma isn't that bad. Having small cell lung cancer, now that's pretty bad. All right. So small cell lung cancer is the thing that's associated with Lambert Eaton, and oftentimes this is given to you in a question where they'll tell you that a patient is presenting with proximal muscle weakness, and then they have impotence and a bunch of other autonomic symptoms, right? And the patient's symptoms seem to get better as the day goes on. Chest X-ray is showing a nodule in the lung or something. What else are you, what is the diagnosis? And you would pick Lambert Eaton. Okay, they can start anywhere. You have to make sure you can make the connections and then bring it back to Lambert Eaton. And that's really all there is to this, right? So I wrote here that for UWorld, myasthenia gravis, the thymus causes autoimmunization in myasthenia gravis and contains muscle-like cells that have acetylcholine receptors. So abnormal antigen-presenting cells within the thymus end up making the antibodies. Right, so in myasthenia gravis, it's not that you just ended up getting a thymoma because of whatever reason, some random connection. It's actually a serious connection. It's related. Your thymus is the guy that's overproducing the thing that's killing everything in myasthenia gravis, killing all your acetylcholine receptors, and any organ that's working too hard is prone to cancer, right? Especially the thymus, which in an adult should not be working so hard. Lambert Eaton, though, it is a very random association. There's no direct connection between why they have small cell lung cancer, but it just happens. Okay. Memorization-wise, I wrote here, myasthenia gravis is more grave, right? More dangerous. You do not have the receptors, and it worsens with use. In Lambert Eaton, something is eating your calcium, decreasing the acetylcholine release. Thus, giving more acetylcholine helps a lot. Right? And that's really the treatment for these people. You just give them acetylcholine, any medication that mimics acetylcholine. If you go back to pharmacology, you would remember there are many medications that kind of worked just like acetylcholine does. There was one that was quote unquote the carbon copy of acetylcholine. I think it was called carbachol. Let me see right here. Yeah, carbachol, right? Carbachol is a carbon copy of acetylcholine. You can give that. Methacholine, right, stimulates muscarinic receptors in the airway when inhaled. You wouldn't really use methacholine for these patients, but these are all medications that kind of act like acetylcholine, right? And they can help. I would mainly say just carbachol is fine for Lambert Eaton patients because they just need acetylcholine. They don't need anything else. And you can see that giving an acetylcholinesterase inhibitor here doesn't really help much, right? Why would it? There's no point. Like they're barely releasing acetylcholine as it is, so acetylcholinesterase wasn't doing much to begin with. There was no acetylcholine for those enzymes. So if you stopped an enzyme that wasn't doing much anyway, it's not going to help here. All right. So myasthenia gravis, you killed your receptors, so you're releasing acetylcholine, but there's no receptor. And once you can't release any more acetylcholine because you got tired, you end up having full-blown muscle weakness. Right. So it worsens with muscle use. Lambert Eaton, you're not releasing calcium to actually release acetylcholine. But the harder you try, the more calcium you release, the more acetylcholine you're able to release. So it improves with muscle use. Now let's take a look at these questions down here. They're all from UWorld. So first one says, a 55-year-old man comes to the office for evaluation of chronic muscle weakness. Over the past several months, he has had increasing difficulty walking upstairs and lately has noticed difficulty combing his hair and lifting objects overhead. His temperature is 98, blood pressure is fine. Pulse is okay. On exam, he has symmetric proximal muscle weakness and mild muscle tenderness, but no skin rash. So, first of all, this is a man. So we're not really thinking dermatomyositis, myositis, that quickly, right? But then you realize that it's symmetric. If it's symmetric, that's usually something autoimmune, and most of those other autoimmune diseases are really, really female. So they need to give us something to really help us pick one of those autoimmune diseases over the other. So then they give you something. They tell you muscle biopsy reveals an endomysial mononuclear infiltrate and patchy muscle fiber necrosis. Endomysial inflammation is one of the myositises that we just looked at right now. And the endo one was the one that just covers one muscle fiber, right? And there are many muscle fibers, so you go ahead and you understand that this patient has polymyositis, right? Polymyositis, and poly is going to use the bigger number, which is CD8 positive. So this person, although not a female, actually has polymyositis. And what antibody are you going to pick? You're going to pick the histidine tRNA synthetase. Remember, there were other antibodies too, right? Anti-JOL1 is the histidine. There's the signal recognition particle antibodies, helicase, mitochondria antibodies. Any of those. They could even put the anti-nuclear antibodies, but it's not exactly specific to dermatomyositis and polymyositis. This patient has polymyositis because dermatomyositis is the one that has a rash. That's why they told you he doesn't have a rash. Right? Dermatomyositis has a rash. Myasthenia gravis and Lambert Eaton, they cause episodic weakness and are associated with thymoma and small cell lung cancer respectively. And for you to be able to pick one over the other, they would have to tell you something about the pathophysiology or the clinical presentation about it worsening with use or improving with use. And those two facts like that, whether something is better or worse with use, are critical, right? We saw the same kind of thing earlier when we were looking at osteoarthritis. Osteoarthritis is a wear and tear arthritis, and that means that the more you use it, the more it hurts, right? So worsens with use. Osteoarthritis, the arthritis gets worse throughout the day. Whereas rheumatoid arthritis, you have morning stiffness. You wake up, right? You wake up, you're going to have symmetric weakness throughout the body, and that just sucks, right? Rheumatoid arthritis was the bigger issue there because autoimmune, it's symmetric, and all that stuff. Next question, you were a 62-year-old woman, has double vision, especially when reading at bedtime. The problem first started several months ago and was intermittent but has worsened over the last 2 weeks and now bothers her constantly. The patient has also developed difficulty chewing and swallowing foods. She usually feels better in the morning. She has no extremity weakness or sensory symptoms. Examination shows bilateral ptosis, weakness of right eye adduction, left eye abduction. Muscle strength is 4 out of 5 in proximal muscles in the upper and lower extremities. Deep tendon reflexes are 2+ throughout. What changes to the postsynaptic muscle cell explains the patient's symptoms. And they really gave it away when they said, it's postsynaptic. They didn't, like UWorld does the most. They tell you so much information for no reason. You didn't need all of that. If they stopped actually right here telling you that she also has difficulty chewing and swallowing foods, right? Intermittent double vision, intermittent difficulties reading, it's all worsening over the last 2 weeks, and difficulty chewing and swallowing. We're really in between like multiple sclerosis, because that's intermittent, and then any of these guys. They really didn't need to give you much more, though. At this point, it was kind of safe to go ahead and say that she most likely has the myasthenia gravis or Lambert Eaton, one of those two, right? But they also went ahead and told you now it's something postsynaptic. Postsynaptic means that it's going to hit the receptor, and what's going to happen, right? So what changes to the postsynaptic muscle cell explains the patient's symptoms. There's going to be a reduced amplitude of motor end plate potential. This patient with progressive diplopia and weakness with mastication, which are both worse at night, along with ptosis and proximal muscle weakness, most likely has myasthenia gravis. Autoantibodies against the postsynaptic receptors decreases the total number of functional acetylcholine receptors, reducing the motor end potential, so the threshold potential is not reached and the muscles do not depolarize. Right? They tried to make the question a little more difficult by using the muscles in terms of electrochemical gradients and talking about the amplitude and whatnot. Really unnecessary, but step 1 does that, right? So you have to be ready for that. The other answer choices just wouldn't make sense. They wouldn't sound like something got weaker. Next one says, 43-year-old man comes to the office with muscle weakness. His symptoms began 6 weeks ago and are worse in the hips and shoulders. Okay, the weakness has had a progressive course so that he is now having difficulty rising from chairs and combing his hair. The patient has had to reduce his regular exercise regimen due to weakness and has requested a modified work schedule for his job as a building maintenance manager. He has no history of neck or spinal injury. Past medical history is insignificant and the patient takes no medications. Muscle biopsy reveals MAC class 1 molecule overexpression on the sarcolemma with CD8 positive lymphocyte infiltration. The moment you see all of that, right, CD8 positive, you know that this is going to be polymyositis, right? Because CD8 positive is polymyositis. There's going to be endomysial inflammation, because endomysial means that you're going to surround one muscle fiber and there are many muscle fibers. What is the most likely diagnosis? You just go ahead and pick polymyositis and that's it. His symmetric muscle weakness and biopsy are typical of polymyositis. Biopsy would also show inflammation, patchy necrosis, and fibrosis of specific muscle fibers. That's exactly what the polymyositis inflammation is. It's inflammation of the endomysium. Okay, so we're seeing from UWorld, right, that polymyositis is the one that's more possible in a man, right? Of all these diseases that we looked at here, all of these starting from all the way from Sjogren, right? When we were up here, Sjogren syndrome, then we got to the seronegative spondyloarthritis, lupus, mixed connective tissue disease, antiphospholipid, polymyalgia, and fibromyalgia. All of these were very typically in female patients, okay? But now polymyositis is one that's pretty cool. This one is happening in men, right? This one is the one that's happening in men. Dermatomyositis is usually going to be a female, as you could tell from these pictures right here, right? Because then they can go ahead and test you on occult malignancy like we saw in this question right here. Okay, so you wanna make sure that if you see a question where it's something with a man and this is NBME and they don't tell you the CD8 positive stuff, you still want to start considering polymyositis because the other ones don't really happen in men. 62-year-old woman, look at this. This one is dermatomyositis as an answer, right? So now we have a female patient. 62-year-old woman comes to the office due to a 3-month history of skin rash on her hands. The rash has not improved despite use of over-the-counter emollients and glucocorticoid creams. In addition, for the last month, she has felt unusually weak and fatigued. She has difficulty with normal daily activities such as climbing stairs and carrying groceries. Her past medical history is significant for hypertension, type 2 diabetes, and COPD. Skin exam findings are shown as an image of Gaucher's papules on her dorsal hands. What is the most likely diagnosis? So that, the rash plus the fact that she just has muscle pain, but, the rash not being photosensitive gives away that it's not lupus. The dermatomyositis is almost always going to be very confusing on step 1 because they're going to really try to make you think it's lupus, and they will have lupus as an answer choice. So make sure you do your best to figure out, what's the core issue here. The core issue in this question is she can't climb stairs. That's really the core issue. She's becoming really weak, right? Difficulty with normal daily activities. It's not lupus, right? So this is just dermatomyositis, and we're done. And the Gaucher's papules, which could have been just a rash, were actually Gaucher's papules, right? So that's the end of that. Next page is the last few things. Yeah, the last few things for musculoskeletal pathology. There's the Raynaud phenomena and the really understanding scleroderma, which is part of Crest. So the Raynaud phenomena, nothing crazy, right? Decreased blood flow to the skin due to arteriolar vasospasm in response to cold or stress. So you see a color change from white to blue to red, and that's kind of what they're showing you here, right? She has some fingers that are very pale white. This one's blue. This is starting to look like it's red, maybe just turning blue or turning away from blue. Most often in the fingers and toes. It's called Raynaud disease when it's just idiopathic, right? Happening for no real reason. But it's Raynaud syndrome when it's secondary to a disease process such as mixed connective tissue disease, lupus, or Crest syndrome. Digital ulceration seen in secondary Raynaud syndrome. Treat with calcium channel blockers. And we talked about this even when we were in cardiovascular, right? Which is where the pharmacology talks about calcium channel blockers. Raynaud phenomena is a pretty big deal. You can see this in patients. They can come describe it to you. And when you see this in the question, you really want to start thinking something's not right with the blood vessels. All right. Scleroderma, this is pretty simple too. Systemic sclerosis. There's a triad of autoimmunity, non-inflammatory vasculopathy, and collagen deposition with fibrosis. So non-inflammatory vasculopathy means that you're kind of killing vessels, but it's not due to inflammation. Commonly, sclerosis of skin manifesting as puffy, taut skin without wrinkles, right? Fingertip pitting, as you can see in image B right here, fingertips got this like crack right here, can involve other systems like renal, right? So scleroderma renal crisis is treated with ACE inhibitors. Pulmonary, such as interstitial fibrosis or pulmonary hypertension. GI with esophageal dysmotility and reflux. And cardiovascular, 75% female. There's two major types. There's the diffuse and the limited, and we're going to see a question about one of them at the bottom. The diffuse scleroderma is widespread skin involvement, right? So diffuse, it's everywhere. Widespread skin involvement, rapid progression, early visceral involvement, associated with anti-scleroderma 70 antibody, right? Which are anti-DNA topoisomerase 1 antibody. And anti-RNA polymerase 3 antibodies, right? So you have antibodies to topoisomerase 1 and RNA polymerase 3, and that's it. And those two antibodies are pretty specific here. You don't really see those antibodies in other diseases. Limited scleroderma has limited skin involvement and is confined mostly to the fingers and face, and it's also with Crest syndrome, right? So now Crest syndrome, you have to remember calcinosis cutis, which is MSC. And that looks like your skin's kind of just ripping off. Anti-centromere antibodies, which are specific to limited scleroderma. Raynaud phenomena, esophageal dysmotility because of the sclerosis, sclerodactyly, and telangiectasia. This has a more benign clinical course. Right? So diffuse scleroderma is going to be everywhere, and that's kind of problematic. You do need to know the antibodies. You do need to know the basic presentation, but make sure you understand the differentials here, right? There's no muscle pain. No muscle pain. So you don't think of any of the other things we've been talking about the past 2 videos. There's no major rash, right? So that cancels out a lot of master choices also. You're just seeing symptoms of tight skin. It's just sclerosis. Just sclerosis. That's it. Look at this question here from UWorld, right? So this one says, a 35-year-old woman comes to the clinic due to severe heartburn that is resistant to over-the-counter antacids, which is very rare. Why would you have heartburn that isn't getting taken care of by over-the-counter antacids? The patient has no known medical problems and takes no other medications. She occasionally has a glass of wine with dinner but does not use tobacco or drugs. So that's perfectly fine. So we can even forget that sentence, delete that sentence out. That sentence didn't tell you anything worthy. Physical exam shows scattered telangiectasias on the face, several ulcers at the tip of the fingers, and small calcium deposits in the soft tissues of the hands and elbows. Already we're seeing Crest, right? We're seeing the calcium, which is the C. We're seeing the telangiectasias, which is the T, right? Ulcers at the tip of the fingers, remember? The calcinosis cutis, this is here. And the ulcers at the skin are going to be for limited scleroderma, right? Because you have the also confined to fingers and face, so that's what they're talking about. This ulceration on the what do they call it? Image B, fingertip pitting, right? So that's what they're talking about here. Which of the following processes is the most likely cause of this patient's heartburn? So why is she having heartburn? Well, we can see that it's very clear from that question that she has Crest syndrome, and there will be esophageal dysmotility, right? What's causing the esophageal dysmotility? Well, this is limited scleroderma. There's sclerosis everywhere, and sclerosis is fibrosis, right? They're very, very similar things. So if you look at all the answer choices, abnormal location of the gastroesophageal junction. Well, if there was an abnormal location of the gastroesophageal junction, that would have a different presentation for the question itself, right? So that's not happening. She's not bulimic. She doesn't try vomiting. So she's not going to pull her she's not going to pull the fundus of the stomach above the diaphragm. That's not what's happening. They're not describing an hourglass stomach. None of that's happening. Increased gastric acid production. Well, if she has Zollinger-Ellison syndrome, maybe, then that would be correct. But we're not seeing anything about Zollinger-Ellison syndrome. We're not seeing anything about pancreatic issues. Choice D says increase in resting lower esophageal sphincter tone. So that's achalasia, right? Increase in resting lower esophageal, and that's not happening, right? In achalasia, you would have her issue, right? Severe heartburn resistant to over-the-counter antacids, but that would have to have something in the question. The question didn't tell you any more that could really help you pick that. In fact, the question has told you it's Crest, right? So you don't pick D. Uncoordinated simultaneous muscle contractions in the lower esophagus. That's a diffuse esophageal spasm. We talked about that as well in GIT in the beginning of GIT path, and this isn't that either, right? So I'm not sure why so many people chose C and E. D seems like a much more reasonable answer than C and E do, so I'm not sure what those students were doing there, but hopefully they learned. The correct answer here is just B, fibrous replacement of the muscularis in the lower esophagus. The lower esophagus has fibrosis going on. This is Crest syndrome. In this question, they gave you the calcinosis, the sclerodactyly, and the telangiectasia. Sclerodactyly, basically, all of this happening. Okay, this is the calcinosis cutis. This is pretty much sclerodactyly, and they describe the telangiectasia in the question as well. And with fingertip ulcers combined, you knew this is limited scleroderma, and she has systemic sclerosis. All right, so that's got the esophageal dysmotility, as they're telling you in the explanation, and that's it. Very straightforward, very easy differentials. You want to make sure you don't confuse yourself. Don't confuse yourself. Pick and choose what you need to know from here. Pick and choose. Don't take everything. Don't let that confuse you. All right, and that's the end of that. In the next video, we'll dive into the dermatology and really, make sure that we can kind of grab everything we need to here and not forget it. So I'll be back later on, and we'll continue on today with dermatology. Thanks a lot for joining us.